Well, hi, everyone, and welcome to Dementia Chats. It's January 26, 2016, and we've vowed not to talk about snow because there's too many people out east in our group that had like almost a yardstick full of it, and they're tired of it. For you that are new to Dementia Chats, this is just a platform, very casual, where we discuss all kinds of topics. It's open to the public, family, people who are living with dementia, absolutely anyone. It's not scripted. And what is so special about Dementia Chats is that our experts actually are diagnosed with dementia. So it allows us to really hear from those living with the disease what's working, what's not working, what are some suggestions for us who are trying to care better, and how would they like to see the world adjust and become dementia friendly. So we always have really interesting conversations. I'm Lori LeBay. For those of you that don't know me, I'm the founder of Alzheimer's Speaks, and basically I started Alzheimer's Speaks and the other various initiatives like Dementia Chats because my mom had dementia for 30 years, and I just felt it was really important for us to raise everyone's voice and have an open conversation and get this disease out of the closet and onto the dinner table and remove the fears and the embarrassment that goes with this. So I'm going to let everybody introduce themselves. Harry, I'm going to start with you. If you want to introduce yourself, please.
Yeah, my name's Harry Urban. I was diagnosed with dementia, probably Alzheimer's, 12 years ago. I live in Pennsylvania under feet of snow, so I don't want to talk about snow. And I'm the founder of Forget Me Not, and I have a blog called mythoughtsondementia.com.
Okay, great. Thank you, Harry. And next we will talk with Michael Ellenbogen. Michael, you want to give yourself or give everyone just a brief description of who you are, and so that they're a little more comfortable with all of our experts.
My name is Mike Ellenbogen. I am 57 years old. I was diagnosed with Alzheimer's at age 49 after struggling for about 10 years. Nowadays, I spend all my time advocating for this particular cause, most of it done behind the scenes where most people don't know what's happening.
Okay, great. And Truthful, you want to introduce yourself?
My full legal name is Truthful Loving Kindness. The doctors are conflicted on my diagnosis. One says dementia, one says mild cognitive impairment. And I blog and I try to pull together links of what other people have written or projects and put that out.
Okay, great. Paulan, will you please introduce yourself?
Sure. My name is Paulan Gordon. I was diagnosed at age 57 with vascular dementia. I'm now 61. And I try to take any opportunity that I can to advocate for the cause. Some of it is one-on-one, and some of it is in a broader concept.
Okay, great. And Elon Caspi helps me facilitate the group. Elon, you want to go ahead and introduce yourself?
Hi, my name is Elon Caspi. I'm a gerontologist and a dementia behavior specialist. I'm here to help Lori mostly behind the scenes, learn from you, from your lived experience, and share what I've learned along the way. So I'm not sure how I'm going to fade out into the background because it's my first time on Zoom.
This one you don't have to. You're fine to be live on this one. I think this will be all right. Fine. The way this works on Zoom is everybody who has got a camera can be on camera. We would just ask people to go ahead and mute their microphones, just so we don't get background noise as people pop in and visit, because sometimes people will come and go. This is being recorded, and so it will be available later. We'll put it up on YouTube, so it's nice and easy access. People use them for family meetings, some just are taking notes and learning, and others are using them for staff training. So a little bit of everything there. I see in the back, Elon, you've got your brain in the background. Is that correct?
That's right. That's a picture of the brain hemisphere that I finished carving a couple of months ago, which I shared with you. And I just before Christmas, I gave it to Yale University Cushing Center, which is a brain center. And they're going to display it there, which I'm obviously very thrilled. And I was told that there's about 2,000 school kids coming every year to do tours there beyond other visitors. So there's like hundreds of brains in the jars, but there's nothing to hold in their hands. So now they can hold it. I can bring it closer and just show it briefly if you want.
Sure.
All right. 1 sec.
Yeah, this is kind of a cool concept. They've developed a program for the kids to talk about brain.
All right. Here you go. This is a professional picture of it. It's a little hard to see, but you get a sense of it, I hope.
Yep.
Yeah. And I hope that, you, Lori, offered to maybe do a radio show at one point about this work, about that center, about wood carving, the intersection between arts and neuroscience. So I'm looking forward to that once they're finished completing the display of the brain. And we're creating a booklet with several dozens of images of the entire process, from a raw block all the way to the finished product.
Okay, yeah, so. Definitely. I'd love to do a radio show when you're ready. To move on here, Pauline, you had an idea for a topic of discussion. Do you want to share that with us, and we'll kind of go from there?
Sure. I think the main topic would be, what are the biggest challenges facing the nation regarding dementia? And the some of the subtopics of that is that I've recently had an opportunity to get some input from many people with dementia on what they think are the most important challenges. And it's just, the list goes on and on. The two main topics I saw as I received input was research and education being one, and that's a huge topic in itself. And then the other one is money. It's money for research. It's money for the people who have dementia and their families. All kinds of those are the main topics or main headings that I saw.
And did out of those topics, was there anything that surprised you that was there or wasn't there? Or?
Well, I guess I was a little surprised that people were looking for financial assistance for the families and for the children of people with Alzheimer's. I think they're sometimes the forgotten people.
I agree. True, do you have any comments on what your thoughts are about what the world needs in terms of improving dementia?
I guess for me, the biggie is relationships, because relationships are the basis of communication, and communication is the basis of community. So how can there be, like, quote, dementia-friendly community without the necessary communication between when you're purchasing something and you have symptoms, or the family is trying to manage the symptoms, etc. I think relationships in general are the biggie.
Okay. What I want to do is kind of get everybody's top one, and then we'll go back and revisit them in a little bit more detail. Michael, how about you? What's your one main point that you'd like to see in terms of dementia friendly?
Well, I actually have two that I always focus on, and I've been focusing on them for a long time, is the stigma and the funding. And I think if you break down those categories, they pretty much cover the whole, I guess, dementia arena in many ways to resolve pretty much about everything.
Okay. I'm sorry, Michael, on my end, I don't know why it cut out. I know Zoom normally doesn't do that, but we're talking Lori here in technology. Can you say that one more time?
Sure. The main things that I know of, and I've been saying this for many years, is the stigma and the funding.
Okay.
And I believe that those two categories, when you break them all down, will actually resolve every issue out there related to this particular cause.
Okay, great. Thank you. Harry, how about you?
I think the challenges are different between the people living with this disease and the people caring for us. And my main thing is I like to see more on how we live with this disease, living with this disease. From a person living this disease's standpoint and the viewpoint. I don't understand the funding and things like that. The stigmas no longer bother me, so that doesn't now I'm not saying they're not important. I'm just saying to me they're not important. But I would like to have more understanding on how we can live with this disease. And that's so important.
Okay. And we have a new person who just arrived. Kate, do you want to unmute your mic and just tell people a little bit about who you are?
Okay, I'm Kate Knapp. I'm in Minnesota. I was my mother's caregiver for many years until she passed in 2012. She had Lewy body with all sorts of other good things. And I have now been diagnosed with non-amnesic MCI, which is the kind that heads towards Lewy body if it goes that direction. I have traced back in my family, and I can identify 4 generations where there has been some form of brain disease, probably dementia, and so it's obviously familial for us. So that is me in a nutshell as far as dementia is concerned. I think my biggest issue is the relationship with people who are, especially in earlier stages or mid stages, and how the public relates to it. Getting people to understand dementia a little bit and the entry into dementia a little bit and how to interact with us.
Okay.
I think I want them to get past the fear and understand that we're still pretty bright people.
I think everyone here will agree. Thank you. So I'm going to kind of summarize what everyone said. Paulan was talking about funding, and especially funding for families. And I think that that's a really interesting piece that a lot of people don't understand, how many families struggle with trying to care for a loved one. True had talked about relationships and communication. Michael said stigma and funding, which really do seem to be the 2 umbrellas that kind of encompass what everyone is saying. Harry was talking about, how to live with the disease, and that we have to look at this disease being kind of our tools and our goals and our support maybe being separate from one another. Those who care and those who are diagnosed have different needs, and both need to be looked at, I think, equally well. And then Kate is talking about relationships and kind of removing stigmas and all that stuff kind of falls under education. I'd like to start out talking about, because I think this one we really don't talk about much, as far as funding for families. What kind of funding would help? And Paulan, I'm going to start with you. What do you think would help families? What kind of funding?
Well, I think, it depends on the person's situation, but I think funding there's a tremendous loss of income when you're diagnosed with dementia. If you had a career, you lose it, the family loses the income. And then there's the additional strain of having to have someone come into your home to help take care of the person as they progress with the disease. And then there's the issue of the funding for the children, because their parents are no longer be able to provide.
Okay. True, how about you?
Well, I know when we were caring for relatives, flying respite care was more than we could afford. And that created problems in itself, because the care partner had no respite, which created its own set of problems.
Okay, wonderful. Harry, how about you? What type of funding do you think would be helpful for families?
I think some type of funding has to be for medication. So many of us can't afford medication. In fact, I can almost guarantee that if they would come out with that magical pill today that would cure my dementia, I could not afford it. And I think a lot of times the medication, there has to be a way that we can afford. I know many people that say they don't take the medication because they can't afford it. They live on a fixed income, and with the price of medication going up, they can't afford it. So I think funding has to be looked into.
Okay, that's a good one. I am going to go to Kate next. What do you think families need in terms of funding?
Well, I'm going to go back to when I was caring for Mom mostly. I was still trying to work full-time as a project manager in technology, a very demanding job, usually 60 to 70 hours a week. If I didn't have the help of my sister, a teacher, we couldn't have cared for Mom, plus the help of a wonderful adult daycare center. And as far as funding was concerned, I needed more help at home. Prior to having the help of the daycare center, I was leaving Mom home alone. I had some funding some help from the county or state for a health aide to come in twice a week for 4 hours each day. And that was nowhere near enough. She ended up finding my mother lying by the fireplace with both shoulders broken.
Oh, jeez.
And of course, my mother went into the hospital, was given the wrong drugs. She was given antipsychotic drugs because she was not cooperating with the nurses. Of course, if they had just called us, we could have gotten her to cooperate. And from there on was a steady decline. If the family were trusted to identify what the needs are, then and given adequate funding for those needs, I think that would be a tremendous help.
That's an interesting concept you said about if the family would be trusted, because we live kind of in a box society where fill out this form and we'll submit it to the computer and we'll spit out and see if you meet the criteria. And this disease, doesn't really have specific criteria. It doesn't. I mean, it's just, it ebbs and it flows. so much with each individual diagnosed, with each family, with each environment. And, it really needs, I believe, really needs personalization, which is what you're talking about. Yet we have a lot of people in this world who, if they let families decide what's needed, would abuse the system. I mean, we've seen that over and over and over again, which definitely causes us problems. So, Michael, how about you? What, when it comes to funding for families, what would you like to see?
I think one of the most important things that can be done is creating a tax credit for the people who end up leaving their jobs to take care of their loved ones as a caregiver credit, to be able to put some of that money as a credit back to them. Also, if they are paying for an outside service for a caregiver, that should be able to be deducted even though they don't meet the full criteria on the income tax. You can actually get credit for that on the income tax today if you reach a high enough level. However, this would be above and beyond that.
Okay. So, I'm thinking, I'm just going to play devil's advocate on that one. I'm just thinking of like the child care credit. It's nice. It's a few $1,000s, but it's not money in the pockets. And what I hear from people so often is they need money in their pocket at the moment. They can, and sometimes they can get that refund at the end, which will give them cash. But what I hear from families, and maybe it's just my perception, because I definitely think that's, would be a great addition. I'm not sure it would be enough, because I just hear so many people really struggling living paycheck to paycheck, and I mean even buying food, let alone medication or keeping the heat on during the weather. I mean, they're really struggling with funds. Are others hearing that as well? Go ahead, Michael.
There's actually many resources that people just aren't aware of. You mentioned heat. If you're in a certain income and you can't afford heat, you can reach out. There's places that will actually help you with that. Same with, medications. If you cannot afford certain medications, believe it or not, if you plead to the pharma companies who make that specific medications, you fill out a form, they will provide the medication for free. So I think the resources are out there. I think the people just aren't aware the resources exist, and there's so much information that's overwhelming to fill out some of that paperwork is part of the problem. But there are resources out there for people. They're just not aware of those resources.
Well, and I agree. I think that's a huge problem. And there are, with heat, but I think part of what I see is that people get so overwhelmed, they don't even know where to start. And, when you go to reach out for help, none of this is an easy process. It's all an application. It's slow a lot of times. It's not really user friendly. And I think people in these situations, they need a flippant voice that's actually going to talk to them, not a computer saying push 1 if you want this and do this if you, because their head is spinning already in fear of just trying to keep afloat. And I think that's one of the biggest things that's missing in a lot of our social services and our government things. And I don't know what the answer is to that. I mean, all this stuff costs a lot of money, but I think one of the things I know that we're doing in our Roseville grassroots group is, we've gotten the city involved, and they have dedicated a page, and we're constantly adding more resources for people to be able to tap into. By far, we don't have them all on there, but we just keep adding and adding. And yet, when you do that, that can get confusing too, because there can be too many. So it's trying to figure out how to disseminate this information. And
Lori, if I may, and one of my big mea culpas is a big part of my career was setting up those press 1 and press 2 and all those things that drive people nuts. They were really good when we first introduced them, but they're bad. But is a person with dementia, especially if you make them, you go to like the number 8 or 9 or whatever,
Uh-huh.
the person can't follow them. Or even with MCI, you can't follow them. When we originally set them up, we said 4 numbers, and 4 across and 4 down. And that's all you do to people. And people have gone nuts with them. But anyway, one of the frustrations with technology is people use, the people who set it up go too far.
Mm-hmm. Well, and even with me, you know, and I'm not diagnosed and with symptoms at this point, but I multitask. And so I'm listening to that phone and I'm doing 12 other things and I push that dang button again because I missed what I heard, you know, and it's just like, and part of it is I have to slow down and concentrate. And I think that's part of a societal problem as a whole is most of us are trying to accomplish too many things at one time. And, you know, we don't stay focused. You know, because technology has made it easier, we think we're doing everything really good. And you know, when I dial into one of those phone things, it's like, okay, I know I have to pay better attention. Harry?
So many times there's a stigma that goes along with asking for help.
Mm-hmm.
I know when I'm speaking, I give out several pages of here in Lancaster County where to get help for, but people see that as low income help, and there's a stigma with that they don't want to ask for help, or they don't want anybody to know that they need the help.
Mm-hmm.
You know, things like that, and we have to make it more possible to help those people that stigma goes away. I mean, it's okay to ask for help with your heating or whatever, you know, as long as you qualify for it. Now, along with that, there's so many people out there that are going to scam and take advantage of these programs.
Yeah,
you know, that happens all the time. So they have to get wiser in that. You know, you just don't open up a bucket of money and say, here, take it. You know, you have to make sure that the right people are getting it.
great. True, you had your hand raised. I'm going to go to you first.
I think one of the issues is, yes, programs may be out there, and some of them even our family was aware of at the time, but it required more time than what the partner had available to deal with it. When you've got the person with dementia being without supervision, while you're trying to deal with these things and being on the phone for 2 hours, etc., it's unworkable. You cannot access the programs even if they are available because of the time requirement with all that red tape.
Yeah. Yeah, I know the other day I was on the phone trying to get through to something, and I thought, boy, if I was still caring for my mom, you know, or even watching my grandchild or whatever, you can't always just stay on the phone for the extended period of time to get that help, and then you got to start all over from scratch again. I'm going to go to Michael and then Kate because I both know you both had comments on this. So Michael.
Yeah, I agree with what she just said. I mean, that is a part of the problem that, you know, it's time consuming and everything. But I think the problem you have to look at is there's many bad apples in our society. And it's because of them that we have these problems. And it's how do you manage that? I mean, we all pay for it, unfortunately, because of that. Otherwise, it would be so simple for all of us to get what we need in a timely fashion. Getting back to what Harry said, I have to tell you, he's right. A lot of us don't want that help. We don't want to be given something for free out there. I am one of those people. I mean, I actually had insurance at my work that would have given me for the rest of my life almost $100K salary. Well, because I was terminated, I lost all that. And I ended up facing reality and relying on Social Security, on SSDI. I did not like that. I hate the idea of even knowing I have to be on that. But the end result is I paid for that. I paid for that. That was something I paid for all my life, that if God forbid something did happen, that was my backup plan. Yes, I would have had a plan in place that was above and better, which unfortunately fell through the cracks because of the system again, which I believe that needs to change also. When people with dementia are terminated, they should have a recourse to go back to get the benefits they were entitled to. You know, just like somebody who has cancer, they lost their job because of it. Unfortunately, because I didn't have a diagnosis, I was left out cold. So I think those laws need to change, and we need to work on that until we have a clear, defined way to determine if somebody has the disease or not. So I think people need to understand you're paying for those things. When you are a part of society and you've contributed all your life into these programs, you should be entitled to the programs, and you should not look at it as a handout. It's something you're entitled to because you worked for it.
Yeah. And that's a big mind shift there. Kate, I'm going to go to you and then to Elon.
Okay. Michael, I was in the same boat. Because I was terminated before diagnosis, and I had multiple issues that I could have used, but before I didn't get the disability insurance I have been paying for. I was lucky. I also had the state retirement plan, and so I was able to go and get disability from that, and I'm okay. But what I wanted to say is there are always people who are going to abuse any kind of assistance. That is no reason to not provide it. You can put checks and balances in. There are still going to be people who will be successful at abusing it. That's the risk you take in helping people. And you can't be afraid to help people because somebody else is going to scam the system and get something out of it. You're still helping a large amount of people. So by providing assistance, financial or otherwise, to people with dementia or their families, you're helping so many people. If someone scams it, someone scams it. You build that into the system. And I think that's something to remember. That's kind of part of it.
Okay, I'm going to go back to Michael because you had a comment.
What you say is great, but that's easier said than done. It takes money. There's a pot of money. Where does that money come from? I mean, I wish we had the money that everybody could hand out the money and the government could hand out the money. The problem is, if these scammers steal that money, there's less money for all of us. That's part of the problem. Because the scammers are getting that money, that makes it less for us. So, for example, when I was going to try to get disability, there was a guy that I spoke with. He says, Mike, you don't know how to get the disability. Here, I needed it. I required it because I really had a disability. He was telling me about his friend who was scamming the system, who was able to get all this stuff that I couldn't even get, and he got it like that because he knew how to scam the system, and there was nothing wrong with this guy. I was like fuming, but I didn't say nothing, of course. This was a friend of this guy's friend. But it's like these people know how to scam the system better than us who have the problem.
Yeah, and that is out there, and that will always be out there, sorry to say. Harry, you had a comment as well.
I think a lot of times when you call up for help, the person that you are talking to doesn't know how to talk to somebody with dementia. Okay? And the conversation gets so confusing that the information is misunderstood. I think a lot of training has to be done for people like that. Now they outsource a lot of these calls, and I'm going to be honest with you. A lot of times I call up, I don't understand the person, and probably they don't understand me. You know, that's, I think a lot of times when you call for help, it has to be in your area that somebody is trying to help you, not somebody overseas or whatever. You know, because I have dementia. I have a hard time understanding the basic things. Now, when you get into all the different accents and stuff like that, and some people talk really, really fast, and you know, things like that, they just don't know how to talk to us.
Mm-hmm. Agree. Elon, you had some comments on this topic?
Yeah, I actually have. I have so much to say about it, so I'll have to restrain myself. I want to kind of take it where Michael left it. I completely agree that this is a human rights issue. You and every person with dementia, most people with dementia worked all their lives hard. They put money into the system, and it's their right. You know, it's their right. And I think that you and every person with dementia, doesn't matter what stage of the disease, are teaching us, as the late Professor Tom Kitwood taught us, what is it to be human? You know, what does it mean, interdependence? That we're all at the end of the day interdependent on each other, and we need more exposure to people like you every day. That's why I love what Lori is doing with this platform. So, you know, I think that we have to remember there's underlying themes in this society, and you know, those underlying themes between big pharma, big agri, Wall Street, and we say, oh, we don't have money. We don't have money to support families. We don't have money to support staff and train them and give meaningful activities. And I think it's misleading, because there is a lot of money, but it has to be balanced towards reduction of stigma, education, care, support. In fact, I know and we know, and there's studies that show that if you will invest in interdisciplinary teams that are well-trained, are coming into the home early on, you can prevent a lot of misery, behaviors, safety issues, and also if you invest in close, trusting relationships, both at home and in long-term care homes, you can actually delay disease progression better than any medication out there. And there are studies that show that close relationship between a spouse and a person with dementia delay disease progression significantly. So, and it's about awareness, but who knows about those studies? You know, there's a disconnect between academia and practice. How do we make those hundreds of studies that are already published accessible to people with dementia, that they can understand those articles that are not in academic, terminology? So I can go on and on, but I think that we have to continue and make the shift from biomedical psychiatric model of approach to a person-directed one. And person-directed, it's even more, it's better than person-centered, because person-directed is, person-centered is what we professionals think what people with dementia need. Person-directed is actually getting their input directly, for people with dementia. And that's a big difference that Dr. Ellen Power, who is a wonderful geriatrician and great educator and advocate, talks about in his presentations and books. And until we're not going to do what Michael is saying, every committee that decides anything about people with dementia must have, by definition, a person with dementia. Yes, maybe in early stages, yes, maybe there should be some screening, but we have to have the input anywhere there is a conversation about people with dementia. It's a must. So yeah, if we are a society that takes a preventative approach, then we can actually save a lot of money and provide dignity and humaneness, and learn a little bit about our own humaneness and what it means to develop dementia and what it means to grow old also. So I just wanted to share that. I know it was kind of all over the place, but I had to share that.
Okay, great. I think I like that definition between person-centered, because that's the buzzword, and new one now will be person-directed, which is wonderful. In thinking of how we work here in the U.S. versus the U.K., one of the things that, and I have not been over there, but just from what I've been told is, their nurse and medical professionals, you actually come out to the house. And I'm just thinking, and they do that to save money and have to actually get to know the people, reduce the stress, instead of, a zillion people transporting. It's the nurse going out to the house, or the staff, or whatever, and I wonder if that can ever change here in the U.S., where we really have, we talk about block nurses, but if block nurses would really take on a whole block and really get to know everybody on the block, just not those with needs, but just, we don't have anyone who's connecting our neighborhoods anymore. And I think that there are people who could help and would help if they knew. And again, we've got our hands so tied with HIPAA that nothing can be said. But we could, if people felt comfortable and not shunned, not embarrassed, or not threatened by being talked to by our government or medical officials, because I think all of that happens. People aren't comfortable disclosing because they think it's going to get used against them in some fashion. So we've lost, I think, a lot of trust here in the States in terms how information is being used. But I just think, golly, if there was one person who could kind of connect a community, who could lead a charge, even if it was, and starting with, the National Night Out or something like that, where people just introduced one another and you got to know your neighbors and got to know what's going on. And I don't know. I just think that there's a lot of creative ways that could be looked into that nobody wants to tackle. Maybe we got to pool all of our funds and become a big co-op and say, you know what? Everyone's throwing their paycheck in, no more taxes, throw it in here, and this will be covered, but no one's going to like that either. So, Michael, you had a comment, and then Paulan.
First of all, we're not a social system like the others, and that's part of the reason why you don't have that. But I will tell you this, Lori, it is starting to get the attention of CMS and some others out there, where they're starting to now look at the possibility of, instead of institutionalizing people with dementia, but to see if they can bring the services to the home. They're actually starting to investigate that right now. So I think there's some very good first steps starting to take place, and I think they're trying to figure out the cost factors, whether it's worthy to do that versus putting them in there. So there's some studies that are actually going and taking place right now, and I think over the next couple of years, I think it's going to come back to show favoritism, that it does pay to keep them in the home, because they're going to see that there's better circumstances that come out of that. Plus, it's going to save them money by doing that. And I think you're going to start to see a change, but it's going to be a slow process till we get there. But there are some studies happening as we speak to look at that. So I think it's going to happen here. Real slow, though.
Yeah.
It's going to happen after my time.
They can follow the I don't know, here in Minnesota anyways, in a lot of the cities, they've done that with trash removal, where now it's, instead of having, 20 providers coming into a neighborhood to remove trash, there's one. And, it reduces the carbon imprint, it saves on the roads, and they can reduce the price. There's so many different avenues in terms of reduction, and I think the same thing would go with, if they would do that as a medical model as well. True, you had your hand up? Or is that an old hand up? Old hand up? Okay, Paulan had her hand up. I saw somebody flash a hand. Okay.
I just wanted to add that, if something should happen where we do get this additional money to help the families or whatever, I think one of the biggest issues or concerns is going to be the qualification process. And that's been alluded to a little bit with the scamming and all of that. But I think it's not just, it's the idea that, first of all, companies tend to look at this as a psychiatric illness. And in my company, the situation was that if it was a psychiatric illness, you were not entitled to your long-term care insurance. If it was determined to be a physical illness, I would have had 60% of my income for the rest of my life. And so I think, and I also see qualification process at the Social Security level. You know, people have to wait years before they're able to get their money. I mean, they get back pay, but what do you do in the years while you're waiting? And so I just think the whole qualification process is going to be really difficult. And doctors don't help, because doctors are constantly changing people's diagnosis. You know, they're saying, now you have dementia. Now, no, you don't have dementia. You have mild cognitive disorder. You know, so I think until something gets straightened out there, it's going to be very, very hard to determine who is eligible for these services.
Agree. Harry, did you have a comment? You've been awful quiet here.
I'm taking it all in. I think the qualifications is going to be one of the biggest things. Now, why I say that is, just last week I had a doctor appointment, and I had a wonderful doctor appointment. My blood pressure was good. My diabetes is under control, and all the other ailments I have were good because I'm under medication. They're being controlled. So I'm thinking to myself, if I'm so healthy, why do I have dementia? And you know, my doctor said, Harry, all your tests are good, except your cognitive test. They keep going down. And that's the things that people don't see. You know, so I get labeled as healthy. You know, and people don't know that my test is so poorly with my cognitive abilities. So they might slap a label on me that isn't even true. It's just the perception of how I look and how I feel.
Yep, agree. Linda, do you want to go ahead and mic yourself? I know you had a comment.
Okay, I'm working. That's why I had it that way. I think a lot of the times now where they have changed diagnosing early onset Alzheimer's and going with the mild cognitive impairment is just a way for the government to delay paying disability. Because that's just started within the last year, more so than anything else. So if they can say you have mild cognitive impairment, that does not qualify you for disability. Where Alzheimer's is fast-tracked, and it's mostly an automatic accept.
That's an interesting comment. Michael, any thoughts on that?
Well, personally, I think people have that all misunderstood. When they created, I think it's called the DSM-5, the reason they did that was to add additional avenues out there, because it used to be just one, and it was very unclear to the physician on where somebody stood. I think the labeling of Alzheimer's, or when you're at the first level of the DSM-5, and I don't remember exactly what the terminology is, it's up to the doctor to make that decision. If the doctor can't correlate the right decision, it's the doctor's problem, not the grouping that you're put under. So I think we have to educate the doctors better so they know what they select. You know, and that's part of the problem. I mean, the categories are still the same as having MCI versus the others. That hasn't really changed. I think to qualify not being MCI, it has to affect two skill sets that you have that affects your direct living or something like that. I can't remember the exact definition. And as long as it meets those two, that
it's your daily living, Michael.
What's that?
It's your daily living.
Your daily living. So if you meet those two criteria, it doesn't matter what they are, you automatically qualify under the new rulings. If you don't qualify, and that's really the same as it's always been, even under the other one. The only difference is they've clarified it and expanded it more. So somewhere along the line, you either fall into one category or the other three.
I think that there's still some issues there, and maybe it's on who's processing. Because, I mean, I still hear also often people with dementia in different modes, it's 2 and 3 times they're applying for disability. And I mean, the joke used to be, you know, 3rd time's the charm. And like it was, I don't know. But I've heard that from people all over the country. And I think it has gotten better. But I don't know if that's part of the process, people not understanding the questions, or people who are reviewing it aren't. But I still don't think it's going through as clearly as the intent might have been for that. Go ahead, Elon.
Well, just wanted to say that, there are, I don't know. I mean, it may delay benefits, and it's probably the case from what, your experience. I don't have experience with that. I think that it comes down to whether it's MCI or dementia or any other brain disease, whether it impacts, as you implied earlier, the person's ability to function independently, safely. And I think that's what it should come down to. There should be an individualized assessment that is professional. Dementia has different forms of dementia, and MCI has probably different causes, impacts every person differently. There's other, we can't separate MCI from aging. We can't separate MCI from other health conditions. So it's got to be a holistic, comprehensive assessment, individualized person, bless you, to see whether what parts of the person's actual ability to function effectively, independently, and safely anywhere is impacted, and that should be the determining factor, whether it's MCI or not. I should say that to me, I think MCI in general, it's a blessing that there is this concept, because we really need to work on early detection, continue, because we know that at least half are not diagnosed nationally ever at any point of the disease from the day they develop the symptoms until they die. And so we need to work on early detection, continue putting efforts, but as long as the MCI concept and the practices that go along are used professionally, humanely, and responsibly by pharmaceutical companies and drug development efforts, and not abusing this concept to make profits on the back of people with dementia and their families are already struggling personally and financially and medically. So that's one piece that I wanted to mention. And the other thing I want to mention, kind of to take a step back, is you kind of ask, what would you want to see different early on in this program? And to me, it's striking as outrageous that there are people in long-term care homes, most people in long-term care homes, people with dementia and nursing home, assisted living, but this does not exclude family members and who provide the support and the care at home, which the majority of people with dementia live at home, that there's the issue of not enough staffing. So family members are also severely understaffed, if you will. It's no surprise that one of the groundbreaking book in this field is the 36-hour day. So a lot of understaffing in nursing homes, assisted living. The part that I don't accept, and I think it's outrageous, is that if someone would tell me that the staff baby ratio in the daycare where my baby girl was 12 months, in a week, is going to be cared for. The ratio will be 1 to 12 babies, one trained staff member for 12 babies, or 11 babies, or 14 or 15 babies. I would probably have a tent there next to the day center 24/7 for a year to change that. And it's striking me that as a society, we're accepting it, that it's okay to provide care for people with dementia and people with serious mental illness and other health conditions in nursing homes. And the same is true at home with family members, with a staff resident ratio of 1 to 12 and 1 to 15 and 1 to 10. This is a recipe for a disaster, and it's actually happening. There's a lot of suffering and a lot of behaviors and a lot of safety issues and injuries and death all across the board. There are some excellent places, but it just strikes me as amazing that society actually accepts that, when if you ask any legislator or congressman or woman if they would be okay if their baby would be cared for, with a staff resident ratio of 1 to 12, it would be changed. It would probably be changed. I'm not familiar with staffing ratios in daycare. I'm familiar with the one my daughter is at, but it's just
1 to 4.
It just strikes me as amazing.
It's 1 to 4.
Is it?
1 to 4.
Jan, did you have a comment?
Yeah, I was going to make a comment back on what you were talking about a few minutes ago about having nurses and doctors who are familiar with people in the community. And I think if we look back at history, there was a point in time when we had that, and we had the milkman, and we had the mailman, and we had the police officer. And what we need to look at is what changed that in order to know what needs to be addressed to change it back.
Mm-hmm. Good point. Good point. Harry?
I think it goes back to, I said it several years now, I believe in neighborhood memory cafes. Okay? I believe in a place that the neighborhood, the area can get together and discuss the problems. Now, if we would be able to have neighborhood memory cafes in every neighborhood of every town, people would get to know the neighbors. They would know the people that needs help and the ones that are able to give help. But that concept is not catching on, because of every time I bring it up at a council meeting or something like that, there's no funding for that.
Mm-hmm. Okay, I'm going to go to True first and then to you, Paulan, and we just have a couple of minutes left. So,
Okay.
True?
I wanted to say that when we first got here to this town, my medical doctor took his weekends and visited and went to his patients who could not make it to the facility. It was when he ran out of money for the overhead of holding an office, that he had to go in with everybody else and go in with their stuff and go in with the services provided. When it was individual, then he could do it. But when he went in with the group, he could no longer do it.
Yeah, very interesting. Paulan?
It was a fleeting thought, and it's passed. I'm sorry.
Go ahead.
No, I
Jan
said-
had her hand up.
Yeah, I lost my train of thought.
Oh, okay, sounds good. Thank you. I wanted to make a comment, backtracking onto something we were talking about with mild cognitive impairment. In terms of, I think it's really important, we talked about this many times in terms of the words we choose. One of the things that I heard so many people be upset with when they were diagnosed with Alzheimer's, and then all of a sudden they were changed to mild cognitive impairment, was, hey, there's nothing mild about this. Walk in my shoes. Nothing has changed. And we had early onset Alzheimer's, using a term like early onset cognitive impairment might be better than trying to label a stage in terms of where it's at, in terms of degree. Because I think that's where some of the frustration comes from. And I think part of the stigma comes from. Well, it's not so bad. This has been a really, really interesting conversation, and I appreciate everybody adding to it. Michael, go ahead.
Real quick, one of the main reasons they made that change, it was the stigma. They didn't want to be labeled dementia. That was one of the key reasons they made that change.
Yeah. And but I think it's the word mild that triggers people, because I don't think anybody at any level of this disease feels that it's mild. You know, when it hits, in compared to end stages, yeah, but in terms of perceptions, I think it was a misstep on that, and that's just me, you know. Let's see, there's one more comment in the chat box I just want to look at and see if I missed anything. Nope, I think it's an old one. Well, again, I want to thank everybody so much. Really, really interesting conversation. Again, we would like to hear from others in terms of, you know, what do we need to do to really improve dementia awareness, and you know, how does that look? Our next Dementia Chats will be looks like February 9th. And that one actually is going to be iffy for me because I'm going to be traveling. I'm going to be in Seattle, and I'm still waiting for my itinerary because we're doing a whole week in Seattle of dementia awareness and promoting His Neighbor Phil. So I'll let everybody know if we're able to do that or not at this time. But again, I'll get this up and running in the recording. Anybody have any last comments? I know we're like a minute over. Elon, go ahead.
Yeah, I just wanted to share that a few weeks ago, I published an editorial in the Journal of the American Medical Director Association about the circumstances surrounding the death of 40 elders as a result of resident-to-resident interactions in the context of dementia. And I just posted the link there. And among other recommendations, it points that we need much stronger and adequate staffing levels in nursing home and assisted living residences, and also to train staff well in the proactive interventions to prevent those behavioral expressions. And so I share that link in the box there. Hopefully people will find it useful, and they can always contact me if they have questions about it. So just wanted to share that.
Okay, great. And let's just, do you want to read the link to people, because they're not going to be able to see that necessarily later on if they're watching this?
Oh, they won't be able to see it?
No.
Well, the link is a little long. So if people want to receive it directly from me, they can just email me.
You want to give your email address?
It's Elon Caspi at gmail.com. So that would be EILON, N as Nancy, and then CASP as Paul, and I at gmail.com. Again, it's my name in one string, Elon Caspi at gmail.com.
Okay, sounds good. Thanks again, everybody. Appreciate your time, and we'll talk soon. Bye-bye.
Bye.
Bye-bye.